I think there's no finer person to do this than Eric Liu. I first heard of him when he went up to Sweden, to Uppsala, and that was part of the training that he had there with the doyen of neuroendocrine tumors, who you all know, Shell Berg. And then when he came back to the United States, to Vanderbilt, to see if he could get a neuroendocrine unit started at Vanderbilt. And he took them from a clean platform over here to where it has become one of the leading and recognized units in the country. And he's blazing a trail that very few people can follow. It's really a pleasure to see that the next generation has arrived, and it's in the form of Eric Liu right here, and that what he is doing for neuroendocrine tumors at Vanderbilt is going to actually show the rest of the country the way. Thanks for being here, Eric. It's a pleasure.
Well, you know, it's my job to replace the older, crazy Chinese guy with a newer Chinese guy. So, you know, I'm just replacing things, that's all. It's such a pleasure to be here, and I really want to thank Bob and Marianne for inviting me to this conference, because it's really so much fun, and I'm very honored to be here. And I think I just want to make a comment. You know, I'm relatively young in this, as you can see, and I was very fortunate to be trained in an amazing place. But when I came back, what I really found was this community was amazing. The physicians you had in this room probably represented about 1,000 years worth of patient care experience. Now, 900 of those years are included in Dr. Warner, so maybe it's a little But alas, there's a lot of great stuff here. And we were very fortunate to have started Gallium-68 at Vanderbilt. And just to give you an idea of the sense of community and camaraderie, I had been so helped by Dr. O'Dorisio, by Odo, and I really saw him as a friend and mentor, that when his nuclear medicine person said, you know, we would love to do it too, I said, great, here's all the paperwork, here's the IND, you know, we need to do this as a team, because the better we do it as a team, the faster we'll get it to patients. Because honestly, I don't do Gallium-68 for my health. And actually, Gallium-68 is relatively uninteresting to me, because it's been so kind of proven in the United States, in Europe. But it wasn't here in the United States. And I really felt this was a tool that needed to be here for you guys. And hopefully with the right teamwork and the right planning and the careful, you know, hopefully we can get this in less than the 4 years that it took to get sandostatin. So I'm very excited and very encouraged, and I hope that we'll have all kinds of new stuff for you guys in the very short future. But I am happy to say that, you know, we had finished up kind of our you know, we were very fortunate, we finished up our safety and efficacy part of our trial. But I reopened it, so we're going to be able to do some more Gallium-68 scans. So if you guys can't get to Iowa, you're welcome to come down to Nashville and Vanderbilt. We'll be happy to scan you. In the meantime, let me tell you about something else. So I've been tasked to talk about PRRT and its effectiveness in Europe. And it's great. Okay, so let's see here. But let me kind of piggyback on Dr. O'Dorisio's great talk. And so, can Gallium-68 save your life? Right? That's a brilliant title. Dramatic, scientific, all at the same time. And it's a very simple answer. Okay, it's very simple. Let me give you just 2 examples of our experience. So, anyone heard of Rod Pommier? Yeah, so Rod, right, great, yeah, Rod Pommier's a great guy. He's talked me through a lot of things and supported me. And he's a wonderful, if you don't know him, he's this great neuroendocrine surgeon in Oregon, very pioneering, forward-thinking. So he does the surgery on this guy. And he takes out a whole bunch of gastrinomas, and his levels are still elevated. And he says, I took everything out. There is nothing left. But his gastroins are still elevated, and he's a scientist, and he said, well, obviously there must be something. So he sent the patient to me from Oregon to have a gallium scan. I said, come on, Rod. Come on. My gallium scan is not better than your fingers. But he was humble, and he said, probably there's something there. Well, in fact, there was something there. And, you know, you don't have to be a nuclear physician to see that black dot right there. See it? Everyone see it? Black dot right there. So I said, well, you know, I can't believe that's true, and so, but he explored the patient. And this is the text I got from Dr. Pommier, okay? So he writes, first of all, you should know that Dr. Palmy likes to take astronomical pictures. So this is Venus traversing the sun. I thought this was really great. He said that to me when he took that. But this is what he wrote. He wrote, Eric just went after this guy's occult gastronoma. It was right where the gallium scan showed it to be. Score 1, true positive for you. I thought that was very exciting. Very exciting. So there's good story number 1. Here's story number 2, which is maybe not so great. But this is a fellow who had metastatic neuroendocrine tumor. Okay, he was operated on at a very, very prestigious institution by a phenomenal surgeon. He was operated again by another phenomenal surgeon. And just I'm going to say this very, very clearly. These are surgeons who I would let operate on me any day of the week, any day, right? And he had this Ochtria scan. And this Ochtria scan showed this kind of remnant thingamabob here in the middle, right? And so the question was, well, do you do more surgery? Do you go after it? Is it real? And I think there was some controversy about it. And so he comes to me. He says he wants a gallium-68 scan. I say, you were just explored by a surgeon of greater skill than me, for sure. And he said, I don't feel well. He said, I don't feel well. I said, okay, I guess it's perfectly reasonable. So we scanned him. And this is what he had. You get the idea. You get the idea. Just can't show it. Okay, well, you get the idea. And luckily, he was operated on by a very fine surgeon, and so he did well from the operation. But could you imagine if he had a bad outcome, maybe by someone who was less experienced? And so he eventually went on for PRRT. So what exactly is PRRT? This is peptide receptor radionuclide therapy, or sometimes called PRRNT. And what it is, okay, is a good therapy, but it doesn't substitute this. Okay, so you've heard this multiple times, right? The first therapy for neuroendocrine is surgery. Right, and the second one is surgery. And the third one is surgery. Well trained, educated. So this is really important, okay? So here's a small bowel, neuroendocrine that I cut out. It's nothing fancy. I mean, here it is. Here it's small. But this is the way to treat these. You've got to cut these things out. Or another pancreatic neuroendocrine tumor, or here's another one, they're small. You've got to get these things out. It's the most important thing, okay? Here's a lung one that we did. But what do you do with this, okay, right? And I am Chinese, and I am very, very patient, and I will sit in the OR for many, many hours, but I can't get all these out. Look, they're in his skull, they're in his bone, they're in his cheek, it's in his chest. I mean, I just can't deal with that. But luckily, there are other people and other therapies that do, and Dr. Del Passan will present much more about this and very exciting stuff. But this is the basic principle. You're about to get PRRT 101, okay? Each of your tumors, okay, has this kind of picture in it. Here's the cell membrane. There are multiple types of somatostatin receptors, and they bind to somatostatin, okay? And 1, 2, 3, 4, 5. We are very, very blessed in our field to not only have a tumor that not only has a target, but we also have a guided missile for it, right? I mean, this is like the holy grail of tumors that we deal with, and this is how it works. Octreotide, and we've learned all about octreotide, binds very, very nicely to somatostatin receptor 2 and 5, very, very well to 2 especially. And what Dr. Odoricio, and Dr. Odoricio kind of mentioned this, and we'll define it a little bit better, is that so what we have right now is you have things called SRS, so somatostatin receptor scintigraphy. So kind of how do you take pictures based on somatostatin, functional imaging. Right now, most of us do it by SPECT, single photon emission computed-tomography. But that's kind of like sitting in an airplane and looking at a flashlight flashing at the picture. You know there's something there, but you can't quite make it out. So the other technology that's really emerged is something called positron emission tomography. Why is that different? Because it's a different physics. Okay? The nature of it is completely different. Rather than having a flashlight flash at you or a lamp flash at you, it's like taking a laser beam and shining it at you. Okay? And so you can see exactly where it comes from. It gives you good high resolution. But then there's this peptide receptor radionuclide therapy, and that's when you really can do something neat and magical with it. And this is where the idea of theranostics comes in. You not only do diagnostics, but you do therapy. Now I, and Dr. Wang, Dr. Boudreau, and Dr. Howe have been doing theranostics for a long, long time. This is the diagnostic tool, and these are the therapeutic tools. It works very, very well. But there are other ways to do it too. And so that's what we're going to talk about today. So what did we say? What did Dr. Orusu just present to you? Essentially, he said, okay, you have a target, your somatostatin receptor. You have a guided missile, which is your octreotide, okay? And you can hook a light bulb behind it, all right? And depending on the quality of the light bulb, you can see the different qualities of picture, okay? And we call that somatostatin receptor scintigraphy, so pictures, essentially. Well, what if you took that and put a bomb behind it, right? And that's really what we want to do, because if you put the bomb, you can treat it. And that's what we call peptide receptor radionuclide therapy. So here's just kind of a little bit of graphic. So just imagine this is your somatostatin receptor, that's your tumor cell. Along comes your octreotide, right, which we use right now for therapy to treat your, mostly for your symptoms and things like that, and some tumor suppression. And you hook a bomb behind it. The particular bomb that Dr. Krenning, Eric Krenning from the Netherlands chose was lutetium-177, and it was very, very clever. And I'll tell you why. So you take that, it binds to the receptors, and the receptors continually irradiate the tumors. I mean, it's just, makes a lot of sense, right? Makes a lot of sense. And the great thing about it is that now you have all these tumors, right? And you've now injected all these, lutetium nuclei in there, and they do this. They continually irradiate these tumors for weeks, okay? And then it wears off, and then you radiate it again. It wears off, and you give it again. And you can give it several times until you see a good response. Now, for those of you who love chemistry, okay, yeah, there must be someone in here who loves chemistry. These are the two atomic elements that we're dealing with. Okay, we're dealing with something called yttrium, so Y, which is right there, and something called lutetium down there. Now, I do read the literature a fair amount, and I always cringe a little bit because they always spell lutetium wrong. It's really spelled this way. But I overlook it. So what are these two elements, and why are they so powerful? Okay, so let's talk first about lutetium, because that's really what I have more experience in. Lutetium is a heavy metal. Okay, it has to be generated in a reactor, so a big nuclear reactor, like the one in The Simpsons, that kind of thing. And what it does is it generates this heavy metal that's radioactive because it has extra neutrons in it. And this particular breakdown of this neutron it actually gives off energy. And the way it gives off energy is in two forms. Something called a beta particle and a gamma particle. So it's a beta and gamma particle. What does that mean? So a beta particle carries a whole bunch of energy with it. It's an electron, essentially. Okay? And when it goes into your cell and it's emitted, it damages the tissue around it. And that would be your tumor, right? Now, the reason this is even more brilliant is because it gives off a gamma beam too, which is a photon. And now you can not only give therapy with it, you can actually do imaging lutetium. So that's what's so great. Its half-life, unlike gallium, which is only 68 minutes, which reduces your radiation exposure, is actually about a week. Okay? But you want that, right? The purpose is different. The path length, as Dr. Orusu mentioned, is a little bit shorter. It's about 0.04 to 1.8 millimeters. But it's not perfect, right? Nothing is perfect. So there are some toxicities, and we'll probably hear more about that next. But really, it does affect your kidneys. It can affect your bone marrow, and it can hurt your liver, especially if you have a very, very heavy burden of disease. Now, yttrium-90, and we're very fortunate to have the American expert in yttrium-90 here, Dr. Odorizio, is also a beta emitter. It's a little bit hotter, like he says. Its half-life is about 64 hours. And the reason yttrium-90 is a little bit different is because it has a stronger and longer path length. So what we think is actually maybe you're able to treat larger tumors with it. It too has a bunch of toxicities, so renal and bone marrow. But all in all, considering what these therapies are, they're pretty well tolerated. Here's an example of a case that I got from my good friend Ulrika Garska in Sweden. She had a patient, a 45-year-old guy who had metastatic insulinoma, right? And metastatic insulinoma is a deadly disease because essentially you're living with glucose of 25 and you're passing out constantly. We have some great therapies, published by our friends here in the room, looking at Afinitor, and that's been very effective. But they used lutetium dotatate to treat this guy, and he was in hospice, right? So he was in hospice, and he was really going for a cure, a miracle. So she treats him with the lutetium, and she treats him with just a couple of therapies because it's the first time, essentially the first time she's really started to do it, and she got this response. It was really phenomenal, and he was able to, get back to his life, and he was able to, his quality of life had improved, and he was taken off hospice. It did recur because they stopped the therapy because they didn't know quite how to give it at the time. But it just kind of gives you an idea of who can respond to it and the power it can have in certain circumstances. So let's talk about worldwide PRRT. Okay, so we're going to hear about some stuff being done in Texas. I'm very excited, can't wait to hear about that. But really, most of it's been pioneered, and most of the volume being done right now is in Europe. There are other couple centers in India, I know there's a couple guys in Australia that's doing it, I know in Israel is doing it, and I'm sure, between the people in this room we can think of a couple other places. But this is primarily how it spans out. I don't think the South Americans have started yet. I don't think they've started. But here it is in Europe, okay? And we have to acknowledge the first place it started, which was the Netherlands, a place called Erasmus Medical Center with Dr. Eric Krenning. And really, they've been working on it for several years. But this is what they do. There's several centers in Europe, and these are just the ones that I know about. There are probably more. I'm sure I'm missing them. And it kind of breaks down into this. This was the study that Dr. Oderisi just presented, which is basically their experience with long-term follow-up in 500 patients. And what they found was that you basically responded or you didn't respond. Okay? People kind of broke down into these two classes. And if you had a good response, your survival was good. I mean, it was going to be several years. If you didn't have a response, the results were not as good. You would continue to progress. And in general, the predictors of the people who had longer survival, as you would imagine, is if their disease was stabilized in the short term, if they had less liver involvement, if they had good performance, so they were strong walking in, so maybe they could endure the therapy better. Because if you weren't, you could only get maybe 1 or 2, you'd have some kind of toxicity. People who didn't have weight loss, people who didn't have bone mets, and people who didn't have the more exotic neuroendocrine tumors, so gastrinomas, insulinoma, and PFPomas. And in their experience, they studied 504 patients, and this was not a randomized control trial, so this is more of a kind of a phase 2 trial, almost kind of retrospective in a way. But their progression-free survival was about 40 months, and their median overall survival from the time of first treatment was 46 months. So we're still in the scale of years that we're measuring. And the median overall survival from the time of diagnosis was 128 months. So we're talking about a good 10 years from the diagnosis. So indeed, it is cancer in slow motion. And what you can see in the response rates down at the bottom in the table, I know it's a little bit busy, but you can see most of the patients were treated with carcinoid, and most of the patients did very well. So if you have, it's CR is complete response, PR is a partial response, MR is something a new term they coined, which is minor response. SD is stable disease, and P is progressive disease. And what you can see here, and I'll just do it on this side, is you can see that most of the patients had some kind of stabilization or improvement of their disease, right? The minority of them had actually just people that progressed right on. And you can see even with the general patterns, even among all the patients who had all the different types of neuroendocrine tumors, a lot of them did still pretty well and had some stabilization. And they were up to, they have the longest experience at 504 patients, but a lot of the centers around Europe are starting to catch up. So really it's quite effective. We've learned a lot from the Dutch. This is just a PubMed search in the past year or two, and you can see here that even patients who have bone mets can have some improvement in those bony mets. It seems to improve the control of people who have, very difficult disease, especially with insulinomas. There's a significant improvement in the quality of life of these patients. It can even be used as salvage therapy with a time to progression of 27 months. So in the sense that you give the therapy, you wait, they progress, you give it again. It can actually be used as that kind of even following therapy to itself. And hormonal crisis is relatively uncommon. So one of the things we fear is that, okay, well now you start to kill these tumors and then they explode with serotonin or whatever it is. Well, it's not that common. It's not that common. So it's something that we don't worry about too much. So how about the Swedes? So I trained in Sweden. I'm very biased to the way they do these things because I think it's well thought out and very efficient. What they've taught us is that there's actually individualization. So this whole principle of personalized medicine really is true in everything we do, right? Every operation is a little bit different. Every sequencing of therapy is different. And even how you give the PRRT is very different. And what the Swedes have evaluated, they found, is that if you can actually measure the amount of radioactivity absorbed by the kidney, because that's a very kind of dose-limiting organ, that you can actually give more of the therapy if they can endure it. So that's how you can really personalize it to that particular individual. Ulrika published a paper just this year looking at the treatment of people with poorly differentiated neuroendocrine carcinoma. So we just heard today that in general, and this is absolutely true, Dr. Cole said it's absolutely true, in general, poorly differentiated endocrine carcinomas are very aggressive. They tend not to have somatostatin receptor. And those tend to be kind of what we think of as a small cell, like an aggressive kind of oat cell of the bowel, kind of. But there are aggressive grade 3 neuroendocrine tumors, which are actually better differentiated, okay, maybe kind of a large cell type of appearance. And she's actually treated a few patients like this. In fact, I referred a patient over to them who had a very aggressive tumor, and she's actually doing very, very well. So there may be a role for this if we can pick the right patients, as always. And it can be used for bronchial carcinoids. I emailed my friend Don Gromberg last week. I said, Don, I got to give this talk. You got to send me something. Send me something good. So he sent me this, and he said, well, we've actually studied some of our bronchial carcinoids, and as Dr. Woltering was kind enough to advertise, I am a GI surgeon actually by trade. That's what I do for a living. But I really feel like some of the lung carcinoids are not well addressed here in the United States, and so hopefully we can do more for them. And luckily I was trained by Dr. Gromberg, so I have some experience with lung carcinoids, and this is what he presented to me. He said, well, we've actually done PRT for several of our patients, and it's been really quite good. You can see here, this is a relatively small study, I will admit that to you. This is about 12 patients, exactly 12 patients. They had a partial response, about half of them, stabilization in 40% of them, and only one of their patients progressed. So you can see the majority actually still had a very good response, even in the bronchial carcinoids, which we don't kind of traditionally think of as being as responsive as the Medica class of carcinoids. And then you can look at but what's really nice for me is I think the side effect profile is pretty good. You can see the amount of toxicity is relatively low. Here, these are grade 1 and grade 2 kind of effects, especially you can see here bone marrow and renal toxicity. And it was relatively unusual for them to have a very aggressive or a very difficult complication, a grade 3 complication. So I thought that was actually really terrific. And Ulrika emailed me with her experience of what they've been doing in Uppsala, and it's just phenomenal. You know, when I trained with them back in 2009, I thought they were doing a lot. And even since then, they've done even more. And this is going back to 2005 when they just kind of got their feet wet with 9, and it just exploded. So I love to think about, you know, what Dr. Del Posan's going to tell us about, and hopefully with our PRT trial, if this ever comes, we may be doing hundreds of treatments here in the United States. I will continue to dream. And one of the interesting things is they're very, like I told you, very evidence-based people. And so based on their experience with the individualized therapy, they said, look, if I can give more, I'm going to give more. So as of last year, you can see the majority of their patients have received 4 therapies. And the reason 4 is because that's the standard protocol that came from the Dutch. Okay, they would give 4 therapies and just stop. But since they've done more dosimetry, they found, well, I can give more. And so what they're doing is they're giving more and more therapy. So now you see some people have got 9 treatments, 8 treatments of lutetium and tolerated quite well. So it's a really an evolving field, it's an evolving therapy, we're learning so much more from it. One of the things that's really very interesting too is what we're learning from other places. So the Germans have a wonderful experience too, and they just recently published their kind of pooled national experience. And they actually found that after the initiation of radio PRT, that their overall survival was actually 87 months, right? So maybe if you kind of give it in a special way, you can give it, you know, aggressively, maybe you give it a little bit earlier, you can significantly improve that kind of survival. I think it's very, very exciting. This is pooled data from 5 centers in Germany. You can see here that even, like I mentioned before, I told you, remember, lutetium gives off gamma rays. Well, in fact, you can use it for imaging. And you may detect several more lesions just with that kind of technology. The combination therapy, we heard that already. Maybe you can give them in certain orders. Well, you can actually give yttrium-90 radioembolization to the liver, and you can chase it down, after your PRT. So that can be given safely, and it can be effective. One of the nice things that we learned too from Dr. Baum in Germany is that you can use the gallium-68, perhaps, as Dr. O'Rucio mentioned, to predict the effectiveness of the absorption of the lutetium-177. And so this is a trial of 2 molecules, and just as Dr. Bolton said, they're essentially the same. You kind of get the same idea. So maybe this will be it will no longer be the Altria scans, he said, but it really will be DOTA-octreotide of some sort, or somatostatin analog as a predictor for PRRT. And as Dr. Wang had mentioned, maybe we can, instead of not using indium, maybe we can actually use lutetium as an intraoperative method of detection and therapy. So it's extremely exciting, and there's a lot of contributions. But it's not just there. There are other people. Look, the Poles are starting to give it now. They're getting a really nice experience, and this is kind of a report of what they've experienced. They've treated now 358 patients, and that's really terrific. Their progression-free survival is a little bit shorter. It's about 17 to 44 months, so maybe what they when it first started is where they were. But they were giving this kind of what we call tandem or individual therapy, and that's actually tandem therapy, which is actually very popular with Dr. Baum and the Swiss. What does that mean? Tandem therapy means you get a combination of either the yttrium or the lutetium. Okay, either you give it because someone has, say, very, very large tumors, so you start off with the yttrium, try to get that down, and then chase down the small things with lutetium, versus an individual therapy, which is just one of the isotopes. If they have very small, diffuse kind of miliary disease, maybe you treat just with lutetium. So again, this is where experience comes into play, where individualization comes into play, and maybe it makes a difference. Here's another report using yttrium-90 where they found that about half of their patients were stabilized at 12 months. The Italians have been giving it too, and they've been getting very nice responses. You can see here, 40% are having some kind of remission, another 40% are stabilized, and 17% are progressing. And the Austrians just recently published that, again, the quality of life is significantly improved with PRRT. So there's a lot to this. I think we have to, it really just goes to show that, in fact, cancer can become a chronic disease. But we have to treat all these things, and we have to use every tool in the toolbox to get there. In summary, this comes from Dr. Kwekabum's review paper in Neuroendocrinology. You can see here the yttrium DOTA molecule and the lutetium have better responses than the indium octreotide molecules given. It's been studied, maybe there are a few more studies here compared to where it is, but I think this is maybe where it's going because of the nature and the technologies that's involved. And it's not rocket science. It really isn't. It's kind of low-lying fruit. This is our laboratory at Vanderbilt. You can see the little Vanderbilt Children's Hospital signal back there. And this is it. That's lutetium. You order it. It comes in a jar. You take it out. And you mix. Mix and heat. That's all you do. And it's as amazing as these data are, it is not sexy. You put in an IV. You watch it drip in. You protect the kidneys with some infusion of amino acids and things like that. You let the patient chill out for about a day, make sure they're not too nauseous, and you send them out. And that's it. That's it. But ultimately, you have to put all these things together, and I think you've seen this slide multiple times, and because it really makes a big difference. You have to put all these people together, okay? You have to put together the nuclear medicine people, like I just presented. You've got to have the surgeons, obviously, but the pathologist is unbelievably important. The nurses are incredibly important. The specialists are important. The support group is extremely important. I just joined Facebook. I'm very 21st century, and I see the discussions that people have, and it's very gratifying to me that people have found each other to support each other. And of course, your primary care physician is a big part of it, and that's because it's personalized medicine is such an important element of the way we approach this disease. Here's my team. I'm very proud of them. They're really terrific and wonderful. I used to have a nurse practitioner who I knew was very good because Jean Woltering approved of her, but she has since left, so I don't have her anymore, so I'm very sad about that. But this is our program. We have a website, so if we can help you at all, give us a call. We're happy to help. And just to show you, the Swedes are not all stuffy. Here they are at Coyote Ugly in Nashville, and they're having a very, very good time. This is my friend Don Gronberg. He's a real lung carcinoid specialist who I had the great honor of studying with. And here are my friends Ronald Walker, the nuclear medicine physician, Jeff Clanton, my radiopharmacist. They really helped us get gallium-68 off of the ground. So I'm very blessed to be working with such wonderful people. So if anyone wants to come to Nashville, it's a great town. It's, you know, it's a beautiful city. We have the waterfront, and it's fun. And if you're lucky, you'll see my neighbor Taylor Swift, or maybe this guy having pancakes, or this guy here who needs a haircut, and her, she's very, very sweet. She's very, very nice. And, you know, maybe a couple of these people too. So hopefully I'll see some of you in Nashville and we'll have a good time. So thank you very much for your attention.